Part three, here we go. So I apologize in advance. Some of the information is a little bit redundant, but some of this is sort of intentional just because I think by saying it more than once, there's some reinforcement there. So heart failure. Um, so when a person has chronic heart disease, either hypertension or a heart attack or something which damages the heart can actually start to function at less than full capacity. We call this heart failure, and basically it becomes a little bit harder to maintain your blood pressure, a little bit harder to perfuse all your essential organs. So what happens? Well, the body basically perceives it as if the body is having low blood pressure, so it stimulates the sympathetic nervous system, you increase your heart rate, you clamp down your arteries, your renin-angiotensin system kicks in, you start to retain fluid, you start to clamp down on your arteries. The problem with this is that this will, in the short run, have benefit. It'll increase stroke volume due to the Frank-Starling mechanism. But the problem is that because of the chronic strain on the heart due to the increased beating, the heart will actually start to hypertrophy, especially that left ventricle. And to increase that stroke volume, and it had to increase peripheral resistance, you're going to have to increase your muscle strength just that much more, and that left ventricle continues to hypertrophy. So the other thing that the body does is that when there is failure of the heart, B-type natriuretic peptide is secreted. This originally was called brain type because it was found in the brain first, and ANP was atrial natriuretic peptide. But the problem with that is that we found that the BNP was actually also found in the heart, and interestingly was probably actually more important in the function of the heart than even the ANP was. So what does the BNP does? It increases sodium and water output, natriuretic. Natra meaning sodium, retic meaning urine output. So it gets rid of some of your sodium, it gets rid of some of your water. It also lowers your norepinephrine, your angiotensin, and your antidiuretic hormone levels. And basically, it's a brake to prevent things from getting too extreme. The problem with this is that the body can only produce so much BNP, although the levels will continue to go up and up and up. And we've all seen people with very high BNP levels probably. But the effect actually starts to wear off. So these things definitely work really well for the short run. And the problem is that eventually the hypertrophy and the other problems will actually lower cardiac function. So the hypertrophy causes the heartbeat to be less effective just because you got that big overgrown muscle. The alpha effects raise the blood pressure, the higher heart rate shortens the filling time and decreases the stroke volume, and then eventually the BNP effect runs out as well. So what do? Well, we try to offset all of those things and then support the output of the heart. So we have to decrease the needs of the heart. And one of the ways that we do that is with beta blockers. So we decrease the cardiac need for oxygen by decreasing the beta output. And we also try to make the heart more efficient. So to decrease that need, we'll try to decrease preload. ACE inhibitors will decrease that preload. Basically anything that decreases the amount of fluid in the body decreases preload. Diuretics, of course, then do the same thing. ARBs are essentially the same thing as ACE inhibitors. They just work at a different point in that cascade. But they just have the same benefit as far as heart failure. We'll also try to decrease afterload. Well, ACE inhibitors decrease afterload by causing that vasodilatation. Angiotensin converting enzyme actually increases vasoconstriction. So if we inhibit that, we cause it vasodilatation. Alpha blockers can also decrease afterload. This is why lots of times when we use a beta blocker, we'll use one that also has a little bit of alpha blocking effect, which we'll talk about in a minute. So the beta blockers definitely do have a benefit. They decrease the heart oxygen needs. And the other drug that we sometimes use, although you won't see it used very commonly, is digoxin, which slows and strengthens the heart. This is the mainstay of therapy back in the 50s, 60s, and 70s. What we found was that it really didn't improve quantity of life, but we do know that it does improve quality of life. So there's a newer medicine that now has a angiotensin receptor blocker, valsartan, in it, but also has a new medicine called sacubitril in it. The Paradigm heart failure study did show benefit of this medicine over the comparison with an ACE inhibitor. Interestingly, the sacubitril actually is a neprilysin blocker, which raises the levels of BNP in the body. So it actually works to increase that natural level of BNP, which does seem to help compensate for heart issues. Interestingly, it does not work very well at all when used alone. And we did actually use B-type natriuretic peptide as an intravenous medicine in the ICU for a while. We really found it didn't work that well. In combination, however, with an ARB, it does seem to work pretty well. So dysrhythmias. Well, dysrhythmias or arrhythmias are basically the same thing. I prefer the term dysrhythmia because it means an abnormal or a bad rhythm. Arrhythmia infers to me that there is no rhythm, and I'm not sure that that's an accurate description of the issue. Beta blockers are class 2 in the Vaughan Williams classification system. We all know what those are. Calcium blockers are class 4. So really the ones that we're more interested in are the class 1s and the class 3s. Class 1 works by blocking the sodium channels. Flecainide is an example of something that does that. There's other dysrhythmia medications that can be used. And then the potassium blockers, such as amiodarone or sotalol, are the potassium blockers and work by that channel. So we do talk about the Vaughan Williams classification system. Most rhythm issues are managed by cardiology. We really don't usually manage them just because there's lots at stake here, and it usually is better if a specialist does manage them. That being said, even though we think of these as cardiologist drugs, there are times where we will end up managing them and adjusting them. And even if we don't, when these patients are on these medications, we have to know them and understand them so that we know the implications for the other medications that they're on, because the cardiologists are not really going to pay attention to medications that are not cardiovascular medications. Most of the class 1s and class 3s are QT prolonging medications. And QT prolongation can be completely lethal. So we need to be very careful with these medications. In certain combinations, they can be extremely problematic. So looking at the type 1s, flecainide is a 1C. It's used in atrial fibrillation, supraventricular tachycardia, and Wolff-Parkinson-White syndrome. WPW is a not infrequent condition, and it is a bit difficult to diagnose. Most of these medications have a narrow therapeutic index, which means the distance between their therapeutic dose and their toxic dose is not all that far apart. Thus, they need to be managed carefully. Sometimes you need to do levels. Either way, you need to be careful of interactions to make sure that they don't go up or down. Now, the type 3s, amiodarone and sotalol, are the most common ones. Sotalol throws a lot of people off because the -al suffix really makes them think it's a beta blocker. And in fact, it is, but it also is a type 3. So it is both a type 2 and a type 3. It has characteristics of both. Amiodarone is a pure type 3. It's a potassium blocker. And again, it can cause lots of side effects, including skin issues, pulmonary fibrosis, ruddiness to the skin. It's a medication that is not without risks. Cardiovascular professionals often put people on it and then don't have to worry about them later on so much. So we do need to watch it and make sure that people aren't getting the side effects and consider other alternative treatments. You can't use quinolones with any of these medicines because they really will prolong the QT interval. There's lots of other QT interval drugs that we need to pay attention to. This website has a lot of the information about it, although if you just search QT interval problems or QT prolongation problems, you'll get 5 or 6 websites which give you the information. Okay, so let's move a little bit on to hypertension. This is actually the algorithm for JNC8. And basically you can see it's a fairly complex but not overwhelming algorithm. Lots of information on here, and we will talk about it as we go along. So before we talk about JNC8 or the 2017 hypertension guidelines, let's talk about some basics in regards to blood pressure. Now, JNC8 does not include stage 1 and stage 2. The later classification has restored those. And basically, I'm not sure that these are particularly useful classifications, just because people tend to move from one classification to the other. If your blood pressure is high and then you calm down some, you go from classification class 2 to class 1. Not sure that it's useful, but some people do find it useful and do use that classification system. When you're measuring the blood pressure, you need to make sure you do it right. We'll talk in a minute about the appropriate way to take a blood pressure. But there's also other ways. Ambulatory blood pressure monitoring is frequently used in Europe. Unfortunately, insurance companies will not pay for it here in the United States, so we almost never hear of it being done here in the States. On the other hand, a lot of patients will take their blood pressure at home. You need to make sure that their cuff is measuring accurately, so they may need to come in and have it calibrated and compared to the office cuffs. But I do really rely on patients taking their blood pressure at home. There's a lot of other things that we need to do when people have high blood pressure. We need to do laboratory testing. Sometimes there's other diagnostic procedures such as a cardiogram and others, and we'll talk about that. So when you're measuring the blood pressure in the office, you can take a blood pressure either by palpation or using the auscultatory method. The normal way is to take it by auscultation with a properly calibrated and validated instrument. The patient should be seated quietly for 5 minutes in a chair, feet on the floor, and the arms supported at heart level. So it is best to have chairs with arms on them. That's also best, to be honest with you, as far as elderly people trying to get up. But unfortunately, not all office chairs have that feature. You should not really take blood pressure when the person is at the exam table, just because it's more likely to be inaccurate. You should make sure the cuff is appropriately sized. You should make sure that if there's any question that two measurements are made. And basically the other thing we need to do is we need to make sure that we give people an idea of what our goals are for them. So at least 1 out of 6 people in the United States have hypertension. It's very common and potentially problematic. The risk of cardiovascular disease is consistent in regards to it. We do find that the increase in blood pressure is correlated to increased risk. The JNC7 folks basically said that for every 12 millimeter reduction that we get, we should prevent 1 death for every 11 patients treated. The problem with that is that Cochrane really came to a conclusion that the people with mild hypertension, i.e. usually stage 1 hypertension, they did not find any real benefit when they did the analysis. So we do know that people with substantially elevated blood pressure are at substantially greater risk of stroke and heart attack. People with mildly elevated blood pressures, the jury is still out. In a minute, we'll talk about the difference between JNC 8 and the 2017 guidelines. The 2017 guidelines are really based in great part on the SPRINT study. The SPRINT study was really done with people with known cardiovascular disease, and it really did suggest that keeping people under 120 systolic and 80 diastolic did have benefits. The problem is that in people that are low risk, I'm not sure that we can make that jump. So there is some evidence, as noted, for people with risk that we should be getting them lower. My concern is that getting people lower probably does result in an increased risk of falls. So as noted, we keep having people take them at home. They bring in their logs. Ambulatory measurement is almost never done here in the States. So the normal, as noted, is less than 120 over 80. In JNC 7, the classification system was systolic of 120 to 139 and diastolic of 80 to 89 was pre-hypertension. Stage 1 was 140 to 159 and 90 to 99. And then stage 2 was 160 or greater and is diastolic of 100 or greater. And these are either or. You don't have to have both. Either or will put you in that stage. So risk factors, cardiovascular risk factors, all the stuff that you would expect. Hypertension, cigarette smoking, obesity, decreased activity, elevated lipid problems, diabetes, microalbuminuria, and age, anything over 55 for men, and anything over 65 for women. Family history of premature cardiovascular disease. So all of these make you at greater cardiovascular risk. No real news here. So what are some of the identifiable causes of hypertension? Sleep apnea. We'll continue to talk about sleep apnea. It definitely is associated with hypertension. Treating sleep apnea does seem to bring it down in some people, but not in others. Whether or not there's any long-term cardiovascular benefit for CPAP as a treatment of sleep apnea is assumed but not really proven. Other causes of high blood pressure, you can have drug-induced, you can have kidney disease. Primary aldosteronism is definitely something to keep in mind. It's not very common, but it is definitely something that we may need to test for, especially in younger people with hypertension. Renal vascular disease, people with a renal artery stenosis will definitely develop hypertension. I do think that this is probably more common than any of us realize. Those of you that work in cardiac cath labs know that if they shoot the renals on the way out, that they definitely see a fair number of renal artery stenoses, and sometimes they even stent them as they're coming out. Interestingly, people with renal vascular disease, if you put them on an ACE inhibitor, they're much more likely to bump their potassium and be running creatinine. So this is why we check at least a BMP 4 to 6 weeks after starting an ACE inhibitor. Chronic steroid therapy will raise your blood pressure. FeO will raise your blood pressure, not very common, but something to keep in mind. Usually these people have normal blood pressure alternating with crazy high blood pressures, 300 over 140, and therefore you might look for a FeO. A little bit harder sometimes than you think it's going to be. Most of them are in the lung, but not all of them. So sometimes they're a bit hard to find. Others are on the adrenal glands, And actually, I think that's a little more common than lung, but those are the two places that I tend to look. Coarc of the aorta, unusual to get to an age where you would have this, although it may be an issue in younger people, and thyroid or parathyroid disease. I've actually had a couple of people with parathyroid disease recently. Usually these people you pick up because they have an abnormal calcium level on their metabolic profile, and then you have to work that up to figure out why. Remembering, of course, as we'll discuss in the Labs and Diagnostics course, that you do need to correct that calcium using the albumin. Hippocrates has a good calculator that will do that for you, but just make sure that you don't take the calcium at face value without correcting it using a calculator. So, routine tests with hypertension. All the guidelines tend to recommend a cardiogram at diagnosis. How often to do it afterwards is not really defined by most of the guidelines, although some people will do it annually, some people will do it every other year. To be honest with you, I tend to do it every 3 or 4 years, and then especially when there's symptoms. Urinalysis is useful to look for protein in the urine, blood glucose and hematocrit. Basically, I do a full blood count and chemistry profile. That, of course, would pick up the potassium, creatinine, and calcium as well. And then a lipid profile. I usually do a 10-hour fast. Interestingly, in Europe now, they really are starting to do non-fasting lipid profiles. And there's a few of the cardiologists around that are starting to do that. There's 4 or 5 up at Maine Cardiology, or should I say Maine Medical Partners Cardiology, that are actually starting to do the non-fasting. But for the majority of us still, we do a fasting blood test for the lipid profile. Urinary albumin excretion, or the albumin creatinine ratio, is probably a test that we should be doing more than we do, looking for damage to the kidneys. Stage 1 and stage 2 kidney disease really do not show up on regular laboratory testing. You really do need to do urine testing to find those. And what can you do about that? Well, those people probably, if they do not have renovascular disease, should be on an ACE inhibitor because it is nephroprotective. In addition, they probably should avoid non-steroidal anti-inflammatory medicines. And some people have all of their hypertensives avoid NSAIDs just because of the potential risk to the kidneys. This actually makes the management of pain that much more complicated. You have all these people that are telling us use non-narcotic medications, but the problem is, of course, that the elderly especially have risk to their kidneys associated with NSAIDs. Basically, if you have a person in their 50s, 60s, or 70s that has hypertension onset, we don't do a whole lot more testing. We usually will start them on one medicine. Some people do testing if they need to go to a 3rd or 4th medicine. But at any rate, we're not going to do as extensive testing in older people as we would in young people. In younger people, we're going to think about doing renin and angiotensin and some of the other the other levels that we can do. But in a young person, it's a very different situation. So basically, we see that a reduction in systolic blood pressure does reduce the risk of stroke and heart disease. Therefore, blood pressure is something that we really should be intervening on a fairly regular basis with. So how much benefit do you get? Well, if you lose 10 kilograms, 22 pounds, the average person is going to have a decrease in their systolic blood pressure somewhere between 5 and 20 points. The DASH diet, the dietary approach to stop hypertension diet, you may get 8 to 14 points. Sodium restriction 2 to 8. I personally find that fascinating. This is something because a lot of people don't realize that when you have somebody that you're having a really hard time managing their blood pressure, The specialty that you send them to is nephrology. A lot of people think it's cardiology, but it is in fact nephrology. Sodium restriction is one of the first things they will do. I've learned that only about a third of patients are salt sensitive, but you do need to remember a third of patients are salt sensitive. So even though 2/3 of people will not really benefit from salt restriction, 1/3 of people will get a substantial improvement in their blood pressure, although this would suggest that you really only get up to about 8 points of systolic. Increased activity 4 to 9, decreased alcohol 2 to 8. Is there an optimal level of alcohol? Most people feel that 1 drink for a woman and up to 2 drinks for a man is okay. Obviously, the data is conflicting on this, though. Other special considerations, we'll talk about compelling indications in a minute. So these are things that will make you choose a particular blood pressure medication. Other situations, minority populations, we know that there seems to be some evidence that African Americans do not respond to ACE inhibitors as well as non-African Americans. People with obesity and metabolic issues, we're going to really work to get their blood pressure down as well as keep their lipids down. Left ventricular hypertrophy, we're going to be maybe a little bit more aggressive to try to see if we can reverse that. There does seem to be some evidence that ACE inhibitors and ARBs will in fact reverse that. Peripheral artery disease. Interestingly, how do we diagnose that? Well, we can do ankle brachial indexes where you have people that have their blood pressure taken on their upper extremities and their lower extremities. The lower extremities should be at least 90% of what the upper extremities are. But we also can do other more extensive testing looking for peripheral artery disease and actually have specific measurements. Hypertension in older people. This is very challenging because we do want to control their blood pressure because it does decrease the risk of heart attack and stroke. On the other hand, elderly people, if their blood pressure goes too low, will have a much greater risk of fall, so something we need to keep in mind. Postural hypotension, certain medications such as alpha blockers are notorious for causing this. Anything like diuretics can also wash out too much fluid and people will end up. So if somebody says that they have issues when they stand up quick, it's definitely something that we want to keep in mind. There's a number of different types of dementia. Multi-infarct dementia is one of those. In those people, controlling blood pressure and controlling lipids is really the foundation of therapy. So in those people, we really do want to control their blood pressure. Women with hypertension can be hormonally related. And again, we need to keep altered presentation of heart issues, etc. in mind. Children and adolescents often will require a consult. This is pretty unusual. Hypertensive urgencies and emergencies. And basically, it really comes down to whether or not there's any target organ damage, whether or not you're going to be extremely aggressive or whether you're just going to add another medication and see if you can't get them down. So let's talk about the compelling reasons. So if you have somebody that has heart failure, you're probably going to want to make sure that they're on the 2 medications that are the foundation of heart failure, which are beta blockers and ACE inhibitors. If they can't tolerate an ACE, they should be on an ARB. Lots of times we also want to keep their fluid levels in their body down, so a thiazide diuretic, either chlorothalidone or hydrochlorothiazide are useful. And aldosterone antagonists such as spironolactone tends to really add to the quality of life on those people as well as helping outcomes. After an MI, beta blockers and ACE inhibitors, as well as aldosterone antagonists. Other element of cardiovascular risk, a calcium channel blocker such as amlodipine may have benefit. Diabetes, again, an ACE inhibitor is going to have nephroprotective effect, but all of those should have benefit of keeping the risk of stroke down. Chronic kidney disease, ACEs and ARBs are the hallmark for those. unless you have renal vascular disease, and in those cases, one needs to be extremely careful and may need to even consult a nephrologist to help. Stroke prevention, thiazides and ACE inhibitors. So minority populations, in general, treatment's going to be pretty similar for all demographic groups. We need to keep in mind whether or not people can afford their medication, whether or not they can take something twice a day if that's the approach. Hypertension is definitely a condition that is more prevalent in African Americans, so one needs to be aggressive with screening and pretty aggressive with medications as well. And so therefore, usually we'll start with diuretics or calcium channel blockers with them. Almost always we can add some diuretic, and that will usually give us a benefit which tends to offset. So in other words, if you're going to start an ACE inhibitor on an African American, you may want to start one with a little bit of hydrochlorothiazide or a chlorothalidone in it. The hydrochlorothiazide does come as a combination medicine. A lot of these medicines are on the Walmart $4 list, so they're no more expensive than using the single drug, and it's worth keeping that in mind. Left ventricular hypertrophy is an independent risk factor. It increases the risk of cardiovascular disease. And with aggressive blood pressure management, we often do see regression. The direct vasodilators such as hydralazine and minoxidil don't do that, but that's at least in part why we almost never use those medications for blood pressure anymore. Peripheral artery disease. Basically, peripheral artery disease is an equivalent to a risk factor in ischemic heart disease. So if you've got somebody that's getting claudication, or if you've got somebody that has substantial blockage on their carotid arteries, we need to consider that they are at greater risk of ischemic heart disease. So we do want to control their blood pressure, control their lipids. I don't think that there's usually a role for carotid endarterectomy in those folks unless they're symptomatic with a blockages. On the other hand, sometimes getting a carotid Doppler will give you an idea of just how much peripheral artery disease there is in a patient. Aspirin should be used in these people. Interestingly, the most effective treatment for peripheral artery disease is exercise. So they go out and they exercise, their leg hurts. Basically what you have to tell them is push through it. Keep exercising. It'll increase your circulation. Don't cause yourself horrible pain, but try to have at least a little bit of pain, and there may be a benefit to doing that. Hypertension in older people, the HIVET study really is what we base our treatment approach on. Lots of people over 65 have hypertension. This group has the lowest rate of blood pressure control. And the other thing is that we used to think that isolated systolic hypertension, in which the diastolic is normal but the systolic is high, had less risk. We now know that really it's basically the same risk as someone that has an elevated diastolic as well. We always talk about start low, go slow with the elderly. The thing that people forget is that the thing that we probably should add to that is start low, go slow, but go. Don't just start with a low dose and leave it there. Make sure that you do titrate upward. In fact, sometimes you need higher doses of medications in the elderly just because they're less sensitive to things like beta blockers. And so you may actually need a higher dose, but you will want to start low, titrate upward, but monitor it carefully and keep titrating. So postural hypertension, what exactly is it? So multiple definitions. I put down the definition that said that it was a decrease of 10 millimeters Others feel like it's 20 millimeters. But basically it comes down to whether or not it's associated with dizziness and fainting. Obviously it's more common in people with diabetes. Those are on diuretics, those are on venous dilators, and with some psychotropic drugs as well. So we can do postural hypotension testing. There's really two ways to do that. In people that we're really looking to see whether there's volume deficiency issues, we usually wait 2 minutes between the lying, the sitting, and the standing blood pressures. In people that we're wondering if there's a neurovascular issue, such as elderly people that are developing blunted responses, you may want to do them immediately. So unfortunately, if you look up postural hypotension or orthostatic vital signs, there is no universal agreement on how to do these. So it really comes down to what you're looking for and how you want to instruct people to check those vital signs. Emergency departments almost always do the 2 minutes because they're way more interested in fluid status. But geriatricians and some other folks that do a lot of geriatrics tend to do both the immediate and then sometimes the 2 minute as well. Obviously, if you've got somebody that you're worried about volume depletion, you're going to watch their drug titration very carefully. Dementia, as noted, dementia can be associated with hypertension in people with multi-infarct dementia. We do want to make sure that we watch their blood pressure very carefully. We know that people with hypertension have a statistical increase in their risk of developing dementia and cognitive impairment. So this is one of the many reasons that we should be trying to control blood pressure in people. We do find also that in people who have already started with a little bit of cognitive impairment, if we manage their hypertension carefully, it will slow that progression. So this basically concludes talk number 3 for cardiovascular. As noted, there has been a little bit of redundancy, and there'll be even a little bit more in talk 4. But if you have questions or problems, definitely let me know.